Hi, Dr. Boateng. My name is Teresa Soto Martinez. I am doing my signature assignment today. I am going to read off of the prompt since I did write this also on my soap note assignment. This is my pediatric rotation, and I am doing this rotation at Arcadia Pediatric with Dr. Jasmeet Gill in Arcadia, California. Today I will present a case that was deeply meaningful to me involving a 5-year-old female with behavioral regression following sexual abuse. Why this case was meaningful to me. This case moved beyond acute medical management to the complex intersection of trauma, development, and family systems. It was a powerful lesson in the somatic presentation of psychological distress in children who lack the language to express their trauma. It challenged me to think holistically, to prioritize psychological safety as much as physical exam, and to understand my role as a collaborator in a long-term healing process. It was memorable for its demonstration of profound resilience in both the child and her mother. So I'm going to do a brief case presentation. As usually my videos are very long, so I'm going to try to keep it at the 7-minute mark as much as possible. So subjective-wise, this is a 5-year-old female. The chief complaint was regression in milestones, specifically the patient demonstrated a neurosis in compresses and thumb sucking, which she hadn't done since the age of 3 years old, and increased anxiety. The HPI symptoms began around 2 months after disclosure of sexual abuse by her now incarcerated biological father. The patient is in therapy. Past medical history is non-contributory, and there is a key point: the clear temporal link between trauma and symptom onset was a critical historical clue. Objective, the patient's vital signs were normal. A physical exam was also unremarkable, notably a soft, non-tender abdomen. Pertinent finding was she was quiet, slightly withdrawn child. She clung to her mother and sat on her mother's lap during the physical assessment, which of course we allowed. And then the assessment and critical thinking process. So the differentials, I did consider UTI, constipation, and general anxiety disorder, resources and processes. The history was paramount. The specific severe trauma history made a primary medical etiology less likely. I used evidence-based diagnostic criteria referencing Sheringa's work on early childhood PTSD to structure my thinking. The regression of milestones, a hallmark of early childhood PTSD, was a key feature that distinguished it from generalized anxiety. The absence of physical exam findings for constipation or UTI further supported a psychogenic origin. So the final diagnosis of this case was PTSD in a child less than 6 years of age with secondary functional elimination disorders. Plan and evidence-based practice. So of course my plan had 4 pillars: diagnostic, collaborating with therapists for formal assessment; therapeutic, reinforcing the gold standard treatment, trauma-focused, cognitive behavioral therapy, and this is per Cohen et al. 2018. Educational, teaching the mother about trauma responses, and of course follow-up. I selected this plan because cognitive behavioral therapy is the strongest evidence base for improving PTSD symptoms in sexually abused children. The behavioral plan for a neurosis was chosen to be non-shaming and integrated with the trauma framework. The alternative of treating a neurosis with medication or a strict bell and pad method would have been inappropriate without first addressing the core trauma. Holistic approach and caring science. Collaboration. I collaborated directly with the mother as a primary agent for safety and healing. We discussed cultural considerations, such as respecting their family's approach to coping while offering evidence-based guidance. I emphasized the need for collaboration with the child's therapist, of course with consent, and to create a unified care team. Gene Watson's curative factor, I consciously applied number 8, creating a healing environment at all levels. This was not just physical, but psychosocial. and it meant conducting the exam in a calm and unhurried manner, letting the child stay on her mother's lap while holding her hand, while the child held the mother's hand, and choosing not to perform an unnecessary genital exam as it had no clinical indication for her chief complaint and could be re-traumatizing. This decision physically embodied a healing, non-threatening environment. Holistic care. My care was holistic by treating the regression not as a behavioral problem, but as a communication of distress from her whole being, mind, and body. Addressing mother's anxiety, vulnerable child syndrome as part of the therapeutic equation, and then focusing on long-term psychological recovery and resilience rather than just the immediate symptomatic relief of a neurosis. This case taught me that profound medicine often lies in listening to the story behind the symptoms, in championing the treatments that heal the psyche, and in having the courage to provide care that honors a whole wounded person. Thank you for listening.